So thank you very much, Mario, for organizing such a great conference and for inviting me to speak. I'm rarely an opener. I'm usually a closer. So I have great trepidation actually setting the stage today, but hopefully I'll do a decent job. So my task is to talk about epidemiology of HCC and really evolving trends in epidemiology, as well as screening guidelines for populations at risk. I have no disclosures relevant to this talk. And today I'd like you to come away with an understanding of how the trends are shifting in the epidemiology of HCC, understanding the risk factors for HCC, and appreciating the importance of screening, which really truly is surveillance because we're doing this in an at-risk population. And to kind of delve a little bit into tools that may refine our approach to surveillance. So let's start with epidemiology. And I want to lay the groundwork of why HCC is unique. Okay, so HCC is essentially one patient with two diseases. 80% of people who develop HCC in the setting of cirrhosis. So already their liver is sick. And this governs a lot about what we can and cannot do, or can and should not do, to a patient with HCC. So cirrhosis, as we know, is a fertile ground for the development of cancer, often multifocal cancer. And there are high recurrence rates because really the underlying milieu is oncogenic. And cirrhosis, of course, complicates treatment because the patient is sick at baseline and trial design. So HCC is the only solid organ malignancy that can be diagnosed by imaging alone. And it's the only solid organ malignancy for which transplantation offers a cure, a durable cure, decades of cure. So the onus is on us to find these patients as early as possible and to prolong their life as much as possible, and when it's at all possible, to prolong their life for decades. So that's the stage. So we know that hepatocellular carcinoma is rising in incidence globally, and you heard that it's tripled in the US and over the last 3 decades. It's the leading cause of death in cirrhosis across the globe, and it's the 5th most common cancer in men worldwide and the 2nd leading cause of cancer death. So the rates are actually staggering, and in the US we see only a very small population. So globally there's 841,080 new cases predicted in 2018 and 781,631 deaths across the globe. Okay, so clearly when you look at new cases and deaths, you get an understanding that this is a highly lethal cancer. Okay, in the US, we see about 42,000 new cases per year and 32,000 deaths predicted in 2018. So these are the 2018 Globocan estimates of the incidence and mortality worldwide of liver cancer. And you can see that Asia predominates the scene, but here we are in Northern America, quite high up, okay, in terms of incidence per 100,000. And then you can see that clearly we're not seeing the bulk of HCC, but knowing that it's going up in the past 3 decades, the US has seen much more than we ever saw in the past. So let's talk about the United States. We're here today, this is where we practice. So it's important to know that the lethality of this cancer governs sort of where it sits on these US cancer statistics. And these come from the latest report. You might have heard it was a very rosy report from the American Cancer Society that said that cancer rates have gone down by 27%, which is fantastic, although HCC, unfortunately, is on the rise. So this is a cancer that's going to get more and more attention, probably more and more funding, because unlike other cancers, the incidence is not going down. So it is the 5th leading cause of cancer death in the United States for males, and it's the 7th leading cause of death in the United States, cancer death, for females. So, again, I want you to come away with the idea that this is a highly lethal cancer. So when you look at the US trends in incidence, this is by sex, you can see all the different cancers that were discussed in this report, and clearly we've had some successes. So lung and bronchus you can see is down significantly in males, but you can see that the trends in liver cancer continue to go up for both men and women. That's the sort of teal colored bar at the bottom. So this is something that's highly concerning, and clearly we need to figure out why this is going on, and I'll tell you why it is going on. The other thing to note, again, with lethality is that even if you have localized disease, you really aren't seeing much more than a 30% survival. But in all stages, you're looking at about 17 to 18% survival over time, okay? That's a 5-year survival. So again, we still need critically, good treatments and a way to diagnose these patients as early as possible, clearly to close the gap between survival with localized and all-stage disease, but also to improve overall survival, because 30%, many oncologists would say, is still 30% 5-year survival is not great, okay? We can do better. So what are the risk factors? So the risk factors for HCC is the most important risk factor across the globe is chronic hepatitis B. It's not something we see that prevalently here in the US, but that carries a 5 to 100-fold increased risk. And what's important in this population is that risk goes up significantly when you have advancing fibrosis. So fibrosis and cirrhosis really do govern oncogenesis, and remember that you need to have cascades of inflammation and scarring that lead you to cirrhosis. And so along this pathway is where you develop cancer. And then HCV infection carries a 15 to 20-fold increased risk, and this is clearly the population that we're seeing in the US. Again, there's a 25 to 30-year latency for cirrhosis in patients who develop HCV infection, and not everybody who's infected with HCV develops cirrhosis. The annual rate of developing HCC in a patient with hepatitis C is 1 to 8%, but it's important to know that the longer you have cirrhosis, the more likely you are to develop HCC. So that rate goes up sort of in a compounded fashion. Now, alcoholic cirrhosis is the second leading cause of cirrhosis-related HCC in the USA, okay? So it's important to understand we have a population that drinks heavily. We see a lot of advanced liver disease based on alcohol, and the longer a person has cirrhosis, the more likely they are to develop cancer. So clearly this is a big pool of patients who are at risk. There's no clear etiology for about 30 to 40% of cases in the West. And now these data came out in 2012, but now we know that that's likely related to obesity and metabolic disease. So just having obesity to begin with gives you a 2-fold increased risk of the development of HCC, and diabetes is associated with a 2-fold increased risk. And that's, essentially apart from knowing if that patient has non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. So just obesity and just diabetes carries that 2-fold increased risk. And remember that we're an aging population, and age is a risk factor for all cancer. So we have to think about cancer in the context of our population, which is growing older. So let's talk about surveillance guidelines. So it's important first to understand, there's lots of people in the room from lots of different disciplines, and there really are no primary care or preventive health screening guidelines for HCC. It's an area of significant controversy. We have a lot of guidelines in the liver societies, in the NCCN, but the American Society of Clinical Oncology, for example, doesn't even have screening guidelines. So many primary care doctors, first of all, are overwhelmed with other things. They fail to look for liver disease, but then they don't even have guidelines that govern screening for them. So the onus is not on them to order the ultrasound. So most liver societies, the American, European, and Asian societies, all endorse ultrasound with AFP every 6 months. And that AFP fell out of the screening guidelines, came back into the screening guidelines. AFP is very helpful. So AFP is elevated in about 50% of liver cancers, but if it's negative, it doesn't really change the paradigm. You still need to perform surveillance in patients with cirrhosis every 6 months. And all patients with Hep C and advanced fibrosis or cirrhosis, which is stage 3 and 4 fibrosis, should continue in a surveillance program. And these are combined guidelines from the American Association for the Study of Liver Disease and also the Infectious Disease Society of America. And the reason that they put these guidelines forward is because now we're in an era where we can cure hepatitis C, and we're really not sure how the natural history of HCC is going to change in this post-direct acting antiviral era. So we are in the midst of a changing natural history, and we have to bear that in mind. So anybody who you think has advanced fibrosis, who has underlying hepatitis C, should remain in a surveillance program. And non-cirrhotic patients with chronic hepatitis B are also at risk. And so this is just a map that shows you the estimated liver cancer incidence worldwide in 2012 in men, and this is juxtaposed against viral hepatitis B in the world. And what I really want you to come away with is the fact that where hepatitis B is endemic, HCC is highly prevalent, okay? So we have special screening guidelines for them. So Asian males over 40, Asian females over 50, Africans over 20, anyone with a family history of HCC, they should all be in a screening program. And for the folks with the family history of HCC, you start 10 years earlier than their first-degree relative at the age of their diagnosis of HCC. So if mom got cancer at 40, you'd start screening children at 30. And lifetime risk of developing HCC is 10 to 25%. Obviously, that gets higher, so the 25% folks are more those who acquired hepatitis B at birth. And it's estimated that of the 257 million people infected with hepatitis B globally, somewhere between 35 and 87 million will die. So for those of you who are interested in healthcare policy, this is very low-hanging fruit. There is a vaccine for hepatitis B. We've been vaccinating babies born in the US since 1985. Clearly, this is a huge public health issue, and we should be vaccinating everyone for hepatitis B. Many of us think that this would clearly reduce the risk of HCC. So we have seen a nice decrement in the incidence of HCC in countries that have adopted vaccination protocols. And so that's why in many Asian countries that have of late adopted vaccination protocols, we're seeing less HCC. So this is the surveillance algorithm from the American Association, American Association for the Study of Liver Disease. This is just recently published, and this is a guidance document. If you have the time, you should read it. It's an easy read. It has beautiful graphics, and it really kind of crystallizes what you should be doing for these patients. So we start with a surveillance ultrasound in an at-risk patient, so anyone with cirrhosis and chronic hepatitis B, patients without cirrhosis, and we would do an ultrasound with or without an AFP, and then we have to interpret that ultrasound, and if there's no lesion on the ultrasound, you just continue with a 6-month surveillance exam. If you have a subthreshold lesion, something less than 10 millimeters, then you would just repeat that ultrasound, and you would do that in 3 to 6 months. And obviously, if you have a lesion, anything that's over a centimeter, you would go on to dynamic contrast enhanced imaging. Clearly, there are some people who do not ultrasound well. They may be overweight, they may have other issues. And actually, in our population, that's a big deal because we have a very obese population, and so getting a good ultrasound can be challenging. And in many tertiary care centers and transplant centers, dynamic imaging is done as a matter of course. I'm going to leave the diagnostic imaging to Dr. Weinreb, who's going to go over interpretation of the diagnostic, essentially the multi-phase CT MR imaging. So let's talk about the utility of surveillance. I told you this is controversial. A lot has been written on this, and it's important to know that ultrasound is cost-effective when the annual incidence of this cancer, which it is, greater than 1%. And we know that surveillance is associated with early-stage diagnosis, and when you diagnose patients at an earlier stage, you can offer them more curative therapy. Utilization and sensitivity of surveillance tests have been modeled, and essentially you're supposed to be doing it at least 32% of the time. So your at-risk population, at least 32% of the time should be in a surveillance program, and the test itself should be 42% sensitive. So we reach that with ultrasound. It's at least 60% sensitive, even in the toughest cases. But we're not actually screening 32% of our at-risk population. We're kind of getting better, but earlier reports were dismal, so we do have to increase screening rates. And the evidence favoring surveillance or screening is quite strong, so in many different domains. So this also comes from the 2018 AASLD guidelines. This is actually the guidelines document, which is an exhaustive document. And essentially, the benefits of surveillance are early tumor detection, survival, curative therapy. So for many reasons, we really do need to push for surveillance in patients at risk. And we know that 5-year survival is substantially higher when liver cancer is caught early. So these are SEER data, and you can see that, if you can catch a cancer in a localized manner, then you can offer much more curative therapy. They have much higher 5-year survival. And so this is very important. And we can talk all day about lead time, et cetera. But the point is that there's never going to be a randomized controlled trial with a non-screening arm. So we really do have to figure out ways of studying these populations to determine not just should they be screened. I think we all agree they should be screened, but the question is what's the best modality, what's the best interval, how do you deal with obese populations? And by doing those kinds of studies, we probably will get the granular data that we would have wished for in a randomized controlled trial. They've tried randomized controlled trials in other countries. No one signed up for the non-screening arm. So patients want to be screened. And this just shows you data from 2011 where the screening rates are very low. So routine is 12%. This is in the private sector. 58.5% get inconsistent surveillance. Inconsistent being, maybe a test during, a 2-year time frame. And then none is 30%. So we're really not reaching the bar. Now, these data have improved. But still, we're under 30% in most cases, and even in national health systems like the VA, which has a directive to do surveillance, we're barely hitting about 50%. Okay, so there are many barriers to surveillance. I'm not going to go over them, but as you can imagine, this is a population that has a lot of comorbidities. They have comorbidities that can be substance abuse, mental health disorders, et cetera. So getting them in for screening can be challenging. Any surveillance program requires recall and follow-up, and we're all seeing this now with lung cancer screening. You can start with the best intentions, but then how do you keep people coming back? So there's a lot of systems issues that we have to deal with in getting surveillance underway in a doable way. So let's talk about shifting trends. So the birth cohort is our present problem. The birth cohort are people born between 1945 and 1965 who have a 5 times higher likelihood of having hepatitis C than the rest of our population, okay? That's why the CDC came out with guidelines in 2012 saying all of these people should have at least one-time hepatitis C testing. And at that time when those guidelines were adopted, we saw a surge of HCC because people were getting tested for hepatitis C, finding out that they had hepatitis C, cirrhosis, and liver cancer in one clinic visit. So you can imagine our lives were pretty rough back then. It's gotten better, but we saw a surge once those guidelines came through. So this is the current problem. This is essentially the aging cohort of hepatitis C infected people in the United States. This cohort is actually enriched in the VA. And so I'm going to just show you a pre-direct acting antiviral snapshot of HCC in the VA system in 2013. This paper actually, I don't think these authors, Lauren Best is the lead author, realized what a great paper this is because it really is a snapshot right before DAAs came into play. So you can use this as sort of baseline data. And what you can see in 2013 is that the incidence of HCC was really essentially predominated by hepatitis C, okay? And that the deaths in patients with HCC per 100,000 showed no sign of a plateau. And in the VA, they're still not showing a sign of plateau. So we're clearly not done with the aging hepatitis C population who's at risk. We have probably some more years to get through that before we do see a plateau from this population. And this population is somewhere around 65 years old. Okay, so the mean age of diagnosis in the United States of HCC is 65 years old. So this is an older population. They have other medical problems. We have to keep that in mind. Now, the post-DAA era is a new paradigm, so this is clearly a shifting trend. And we know that in patients who do not have cirrhosis, who attain an SVR after DAA therapy, actually have a lovely survival. So we're seeing tremendous benefit of DAA therapy, and everyone who has hepatitis C theoretically should be treated now because you're going to prevent them from developing advancing fibrosis, and you're going to vastly reduce their risk of HCC. This very steep green line are the people who have cirrhosis who don't attain an SVR, okay? And so DAA-induced SVR is associated with a 71% reduction in HCC risk for all comers. And that is staggering. That's amazing. So, and this is all happening like now. So we're at an incredible time to study this disease. Now, the important caveat here is not to stop surveillance in patients who've attained an SVR. So that's basically a cure of hepatitis C. when they have advanced fibrosis. They're still at risk, okay? So the natural history is evolving. The data is too fresh for us to make any determination. Many studies suggest that although liver stiffness may improve after SVR, cirrhosis and attendant HCC risk remains. So things like elastography and newer techniques to measure stiffness of the liver may not be interpretable in these patients. And clearly we don't have the data to interpret this yet. And the probability of HCC seems to plateau in the second year following SVR. So we're not really sure what the sustained effect is of SVR, especially when people are getting older, getting fatter, getting diabetes. They may have other attendant risks on top of their previous viral infection. And we also know that there's been a significant increase incidence in HCC in the 7-year interval between 2001 and 2007 compared to 2008 to 2014. So what that means is we're diagnosing more HCC. And is that because we have increased awareness, or is that really because these rates are going up? So there's still a lot to be learned from this population. This story is not over by any means. So the next question is, well, hey, what if you started with cancer and people said, oh, you got a cancer, I'm not going to treat your virus? The truth is once you can get a cancer under control, you absolutely should treat the virus. And there was a lot of controversy about, whether these DAA therapies may actually enhance the risk of cancer. They don't. So that data is now out. This is an Italian study that basically shows that in the non-DAA group, they have a much poorer survival, and this is DAA therapy after HCC treatment, okay? And then this study is accepted for publication and was presented at the liver meeting, which basically shows that the risk of HCC recurrence goes down after DAA therapy. Okay, so the onus is on us to treat these patients. And this data is very important because it's much bigger cohorts than were first reported, and the first reports made us very concerned that something was going on with the antiviral medications. So what about fatty liver disease? So the most recent and largest study is a VA study that looked at 296,707 non-alcoholic fatty liver disease patients compared to controls. And there was clearly a much higher incidence of liver cancer in the non-alcoholic fatty liver disease patients. Now these patients, these were all comers, okay? So some had cirrhosis, some didn't have cirrhosis. Clearly, if you have cirrhosis, you have an even higher incidence, okay? So we're talking about 0.21 per 1,000 person years in all comers, and then a 10.1 per 1,000 person years in NAFLD-related cirrhosis, okay? So it's important to know cirrhosis really is the overarching risk. But very scarily, 20% of NAFLD patients with HCC had no evidence of cirrhosis, and we're seeing this more and more clinically, and we're not really sure what to do with it. And it's frightening. And we're seeing these patients come in, they have a lung cancer screen, and the CT of the chest shows a liver lesion, and then lo and behold, they have fatty liver disease, they may or may not have cirrhosis, and they have HCC. And in this study, it certainly showed that patients with NAFLD cirrhosis should be in a surveillance program, and that they met or exceeded the acceptable thresholds for surveillance. And this just is the curve of the cumulative incidence per 1,000 patients, and you can see the huge separation between controls and NAFLD patients. Now, the prevalence of obesity is not entirely to blame here, because what you can see is that in the US, so the obesity map is the colorful map, and the incidence per 100,000 of HCC, this is the Ryerson study that came out in 2016, basically calling to light how high the risk is, or how high the prevalence of HCC is compared to previous decades. And you can see that in places like Connecticut, which has only 20 to 30% obesity, the risk of the prevalence of HCC is quite high. So it's not just obesity per se, it's probably genetic things that underlie obesity. So you can't really superimpose one map on the other, and that has to raise some questions. So what are the other exposures? What are the other risks, okay? Now, I should also say to you that I'm saying that, hey, look, Connecticut's yellow, that's only 20 to 30% obesity, whereas 20 years ago, it was 10% obesity. So the entire shift of the nation has gone towards obesity, and the places in black are places that are more than 35% obese, okay? So there's something happening to our entire epidemiology when you look at obesity, diabetes, et cetera. Now, this is a very important slide because what it shows is for the first time in decades, basically the age-adjusted incidence of HCC in the US in Hispanics has exceeded Asian Pacific Islanders, okay? So why is this? It's likely related to underlying genetic predisposition. So the certain polymorphisms are much higher in Hispanics than in other demographics. So for example, PNPLA3 mutations are much higher in Hispanics and then whites and then blacks. So what's very interesting is if you look at the obesity map, a lot of the obesity map, is sort of in the southern belt, and yet a lot of the HCC incidence is coastal. So how does this deal with sort of population migration? So a lot of this is population health and also population genetics, understanding our predisposing genetics in different immigrant populations and different resident populations. So my observations, and some of these are predictions. First, the natural history of HCV-related HCC continues to evolve in the DA era, and we're not done with this, so you do need to keep reading on this. Patients with hepatitis C cirrhosis are still at very high risk despite cure, so you have to keep them in a surveillance program. And NAFLD-NASH is very likely to become the most common underlying cause of HCC in the future. The prevalence of HCC in NAFLD-NASH patients without cirrhosis is still unclear. So we do not have surveillance guidelines for them, and there is no guideline to put them into a surveillance program. So we're worried about this. I think the guidelines will evolve in the next couple decades, but certainly not right now. Ultrasound is going to be less sensitive in this population, and this population will be older. It's already older, so studies coming out of the VA show that the average age at diagnosis of HCC in this population is 72. So for those of you who are aware of sort of transplant and actuarial survival, many 72-year-olds will never be able to be transplanted. They have a lot of other health conditions. So I think our treatment modalities are going to evolve in this population to meet their age and their comorbidities. And we have to think about those things when we think about treatment that we give to these patients and their overall survival. So there's a lot going on in terms of prioritizing those most in need of surveillance, and there's just a couple slides to show you the idea of developing living models of risk and testing those models as epidemiology evolves for risk stratification, to prioritize resources and to prioritize workflow, and also to diminish psychological harm. When you tell a person they're at risk for a cancer and they need an ultrasound every 6 months, it does a lot to their brain. They're worried, they stay worried. So we really do want to put the right people in a surveillance program and not cause harm in people who perhaps shouldn't be in a surveillance program. So there are risk models now that are available, that actually are available online, and what you can see is that in multivariable analysis, different things are at play in these calculations, right? So when you take away cirrhosis, you're really looking more at BMI, genotype, et cetera, of their virus, and sex. And what we're trying to do is to figure out who's at highest risk. And you can see here that screening wouldn't have been recommended in many of the patients without cirrhosis in that far graph. But, for example, the person in column 4 has a very high risk, and that person should be in a surveillance program. So we're hoping that these models will be used and validated. So in summary, the incidence and death rates of HCC continue to increase. Epidemiology is shifting and will continue to shift in the setting of effective hepatitis C therapy, increasing obesity, and an aging and sick population. And diagnosing HCC at early stages requires identifying at-risk individuals and enrolling them in surveillance programs, which is a systems change. We have to make the system work for our patients. New tools can help us prioritize those at highest risk, because even if we had an ideal system, we would be inundated with people to perform surveillance in. So we do still have to risk prioritize these patients. And the implementation of HCC surveillance programs continues to be very challenging. So hopefully we'll talk more about that today.